Shri Ganesh, can we have your talk, please?
Yeah. Good evening, dear friends, and thank you, Dr. Namrata and Zais, for inviting me to share some interesting cases with the Artevo 800. We got the Artevo 800 almost 1.5 years ago. I was involved in the R&D of this microscope, and we got the first installation, actually the first global installation of this microscope, and I've been using it ever since, and I got so used to it that I don't use the oculars anymore. And I think the previous speakers have covered the technology and the advantages of this system. But I'll just show you some interesting cases which I did this week. And let me just share my screen. Okay, I am a consultant to Carl Zeiss Meditech, and I'm also involved in the development of this product. And like Dr. Tityal and Grewal were discussing, of course, there are a few things you have to turn your head slightly to the side, and this is a higher-end microscope, but I'm sure in a couple of years you will be seeing something different coming up, which basically takes care of all these issues. And of course, I can't speak too much about it, but development is underway. So let me show you 3 cases that I did this week. The first case was an interesting case. I had operated this case as a patient of high myopia. I had operated 11 years ago. He came back with blurring of vision since 2 weeks, and this was the condition. The whole bag and IOL complex was just floating in the anterovitreous. It was dislocated. So I put in a trocar cannula there, and I decided to refixate this lens. You can see it's a 3-piece lens. It's an SI40 lens. And I'm refixating it with a modified M&A technique just through 2 1mm side ports. So this is interesting. This is, of course, the Artevo system. You can see I'm just using 13% light, and I hold this, I make the side ports, I hold the lens and the bag, and then carefully bring it into the anterior chamber. You can see the clarity and the color of the conjunctival vessels. The conjunctival vessels are focused, the iris is focused. So this is about 7x magnification. And this again, I'm doing with the 3D system. This is a complex case. So it's not only for routine cases, but complex cases also. I bring the whole lens bag complex into the anterior chamber. You can see the sommering ring there. And because of the high myopia, weak zonules, this lens bag complex are dislocated. I do an anterivitrectomy. I remove the posterior capsule, and then I'm with the vitrector, I'm basically chewing up the sommering ring there. And after that, I kind of separate the anterior capsule and release it from the lens. Now I have to skin the capsule from the IOL so that the IOL is free. So I take a Sinski there, and then you can see that, like Dr. Rajesh was saying, it's always centered, because you have to be centered when you're doing the microscope, and the recording in HD is excellent. So you can see very well. Your residents also can have the same view as a surgeon. So I'm just kind of releasing the capsule from the optic and also from the haptic. There I go there, and then now I have released it and separating all around with the Sinski. And you can see that now I've released that. This is a silicone lens you can make out from the shiny surface. This is an SI40. In very high myopes, I think it was +2 or something, the lens power. Very high myopes, you can have weak zonules over a period of time. You can. So I'm using this MST forceps to gently release this adherent capsule from the haptic, because the haptic has to be clean. Otherwise, you can't insert it into the needle for a M&A technique. So all these maneuvers are done just through two side ports, and you can see that visualization is excellent. You're sitting up straight, you're looking at the screen, and then you can even do all these small maneuvers. So then I separate it. Now the other haptic has to be released. You have to kind of skin it from the other haptic, the capsular bag. It's quite adherent because it's almost 11 years since the first surgery was done. So I just kind of pull it and then skin it off, and there it comes out. So the last part at the edge of the haptic, which so you can see that now the lens is free in the antechamber. I just remove the capsule. So then I go under the lens and do a vitrectomy, anterior-vitrectomy, to clear the vitreous there. Then the pupil is small now. It's just a 2.5 millimeter pupil. So I use an iris hook. And then I put the iris hook on the right side. And then I mark the diametrically opposite marks. I use a Mendes marker. And then 1.7 millimeters diagonally away, I put the two marks where I have to pass the needle. This is a 27 gauge BD needle, which I bend. And then I pass it on the right side, conjunctival transscleral for about 1.5 millimeters, and then enter. And you can see the needle has come under the iris. Then I go through the other side port with the MST forceps, cannulated forceps, hold the haptic. The depth of field is excellent and the visualization is excellent. So you can do all these maneuvers also, then pass it, railroad it through the 27 gauge needle there. Then I pull out the needle on one side and just leave it there. You can see that. I just leave the needle there. So because I want to check the centration, because if you flange it, then if it's not well centered, again, you'll have a problem. I remove the iris hook there. And I put it on the opposite side, on the other side port. Retract it. This is again so that you don't have to manipulate the haptic a lot, because if you manipulate the haptic, it may twist or bend and then you don't get a proper alignment. Then I pass the 27 gauge needle, again, go under the iris there. I'm able to see it very clearly because of the retracted iris. Go and hold the haptic with the MST forceps. And then it is a little tricky, but I thread it through the first time is a miss, second time I get it in through the needle. And then gently pull it. The pupil is small, so you have to be a little careful, but the IOL again slips under the iris very easily now. I hold the haptic which has come out, and with my left hand, I remove the iris hook, because being ambidextrous kind of helps in these situations. Then I flange it with the thermal cautery. So you get a flange again there, nice flange. And you can see that the lens is very well centered. Then I go on to the other side, release it from the needle. Hold it. Actually, this patient was one-eyed because the other eye, he has myopic degeneration and a foveal scar. So I wanted to do this minimally invasive technique. And again, flange it. You have a nice flange there, adequate flange, and then you just bury it subconjunctivally. And that's basically the procedure where you have refixated the IUL through two 1 mm side ports, minimally invasive, and then you can remove the trocar cannula. You can see the lens is very stable. Just hydrate the side ports a little, and then I remove the trocar cannula, self-sealing, and that's the procedure. This is the coaxial elimination, stereocoaxial. You can see that lens is very well centered. So that is the first case. And the second case is a case of Nanophthalmos. This was a patient who had multiple angle closure attacks, about 7 millimeter axial length. You can see this posterior synechiae. So after giving mannitol and atropine for 3 days, we gave atropine for 3 days, pre-op mannitol. Here I'm doing sclerotomies, 2 sclerotomies in first temporal and temporal, and then I always like to do sclerotomies in such cases because you have a very high risk of effusion. 50 odd years old female, you can see I just incise with a diamond blade. The sclera is very thick, almost 2 millimeters. I go in with a Desmace punch and then punch it. So I have a nice opening. If at all there's a effusion, choroidal effusion, then this takes care of it to sclerotomies. You can make 1 or 2 sclerotomies. And then after that, you can proceed with the surgery. I make a side port, put in viscoat here. I'm using you have to use a good viscoelastic. The ACD is just 1.5 millimeters, so it's quite tricky. Then I have to release the synechiae. So there's a very high risk of choroidal effusion and malignant glaucoma. So you have to take precautions to overcome these two issues. And you can see that because the depth is so good, though the AC is so flat, 1.5 millimeters, I'm able to see with all the clarity. And then this is the main entry. I make a slightly trapezoid incision because the lens is quite thick. It's a 48.5 diopter lens. And I use the Malgin ring because these irises typically are very floppy. And then you can have floppy iris prolapsing, and then you get into a fix. So here I'm using the Malgin ring. Actually, there's no space there. I just put the ring on the iris and then I'm manipulating it to engage the pupil so that I have adequately dilated pupil, which is not floppy. And you can see the cataract also is quite dense. So you have to use a good viscoelastic, viscoelastics. And then I'm doing the capsular rhexis. Again, these cases, the anterocapsule is very convex. So I use a rhexis forceps rather than a needle. It's very difficult to do the rhexis with a needle. Aim for a 4.5 to 5 millimeter rhexis. And that's the completion of the capsular rhexis. And after that, very gentle hydrodissection. See that the nucleus does not pop. Otherwise, very little space there. And then I make the other side port. And I go in, you have to increase the IOP. Here I'm using the Centurion. I increase IOP to 50 millimeters of mercury. And then that's the phaco chop. And you have to do the surgery quickly because again, if you take more time, the risk of choroidal effusion, expulsive again is higher. This is an older patient again, hypertensive, multiple angle closure, attacks, glaucoma. You can see that an iridectomy has already been done. So this is management of the nucleus. Chop and remove the fragments. That's the last fragment being removed. And always put in visco before withdrawing the probes. Maintain the chamber always. Otherwise, if the chamber collapses, even on UBM, the patient had an anterior rotated ciliary body. You have a very high risk of intraop malignant glaucoma aqueous misdirection. So always maintain the chamber. That's the cortex being removed. Again, put in viscoelastic, remove. You can see this is a custom-made lens, 48.5 diopters, from IOCare. So we put in the lens into the capsular bag. And you can see that once you put in the lens, I find that the capsule is very flaccid. And I do a secondary capsulorhexis because I don't want capsular contraction. Because once you remove that large nucleus, the eye is so small, definitely you'll have capsular phimosis. So that's a secondary capsulorhexis. And then I remove the Maligan ring. And you can see that the chamber has deepened very nicely. And then I go in with a vitrector. I increase the size of the iridectomy. Then I do a zonulotomy and a hyaloidotomy. And so that there is a connection between the posterior segment and anterior segment. This prevents the risk of malignant glaucoma. Again, malignant glaucoma risk is very high in these cases. So it is one chamber there, and then I just hydrate the wound. You can suture the wound if you feel that it's not holding. That's the end of the procedure. I just close the conjunctiva where I've done the sclerostomies. And that was management of Nanophthalmos, and this patient is doing very well. We're following her up. I think first day visual acuity was 6/18 because these patients don't improve fully. This is another interesting case which I did, an ICL, and you can see that I make a single incision for the ICL. This is a 2.8 mm incision with a diamond blade, intracameral xylocaine. Then this is my cannula, which I use to inject viscoelastic. I'm using sodium hyaluronate 1% there, and then I inject the lens into the anterior chamber. And again, you can see the Artevo 14% illumination. You can see that the glow is so good, retroillumination. I'm tucking the haptics through the main incision itself. I don't make side ports. This is the Ganesh ICL manipulator, which is available with Epsilon. So you can even inject viscoelastic to maintain the chamber, deepen the chamber, and the undersurface of this cannula is sandblasted. So you can, and it's got a curve so you don't touch the central area of the lens, and you tuck in the haptic. Once I'm done, okay, the ICL is, so everything is going on well and everything looks okay. But then the Artevo has the IOCT. So after I remove the viscoelastic, I'm just aspirating the sodium hyaluronate. It comes out as a bolus. It just takes about 15 seconds. You can aspirate it through the center flow hole there. And once that is done, then I just hydrate the wound. Okay, the case is almost over, but then I use my IOCT and then check the vault. And then you can see that we have a surprise there. Okay. So end of the case, fine, put on the IOCT now and to check the vault. And you can see that that's the IOCT, intraop-OCT. The Artevo 800 has IOCT, and you have a large. You can see the vault is almost about 1,100 microns. So you have a guide there also, 1 millimeter. So each segment is 200 microns. So you have like 1,100 micron vault. So what do we do now? So you can see what I do is I go in with my cannula, irrigating cannula, and I just rotate the lens. This is a non-toric ICL. So when you rotate it from horizontal to vertical, because the vertical sulcus is bigger than the horizontal sulcus. So I rotated it vertically. And then once you rotate it vertically, you can see what is happening to the vault. The vault reduces. And you can see the vault has reduced to about 400 microns now, which is perfect. So from 1,100 microns to 400 microns. This is how the Artevo helps in ICLs. So you don't have to bring back the patient, exchange the lens, or again rotate it. So having an IOCT intraop is very useful in such cases. So these were the 3 interesting cases which I did this week, which I thought I would share with you all. Artevo system is excellent. You can see even at almost 10x magnification, you have both magnification and field, which you don't get with a regular operating microscope. You can see that the lens is focused, cornea is focused. You can see the blood vessels are focused. And of course, all the other advantages that were alluded by the other speakers. Thank you very much for your attention. If there are any questions, we can take them.